Okay, so I said we're starting mouth to anus, right? There's a few things that our book really mentions. I think it's really good. First of all, anorexia, right? So even before food or anything can hit the mouth, it's important that we kind of know about this. When we talk about anorexia, a lot of times we do say it's a diagnosis, right? Like when we went to Western State and we talked about patients with psychiatric diagnoses, anorexia can be a medical diagnosis. It can also be a symptom, right? It's a lack of appetite where people aren't eating. So just make sure we know there's a distinction between those two. If somebody on their chart has anorexia, it's important we know, okay, is this a psychiatric condition that they're choosing not to eat? Or is it a medical condition that they do not want to eat? They don't feel hunger because of the medical issue. It can be really common depending on, I'm sure you guys can think of lots of times, like when maybe you haven't felt like eating, where you feel a little queasy, sick because you had a gastric bug and you were throwing up or diarrhea, or you're in a car and got a little sick. Just lots of things can cause where you don't want to eat. Essentially, the biggest thing we're going to do is make sure that we replace what they're not getting. So if they're not getting fluids, we're replacing fluids. They're not getting nutrients, we're going to replace those. So opposite of anorexia, nausea and vomiting, right? So again, nausea, that's the urge to vomit. That's when you feel like you might vomit. Vomiting is when you actually have something coming out of your stomach. You're expelling those stomach contents. You guys should, I think you have a good grasp on that. So first question is, the nurse is caring for a patient who is vomiting. What activity can the nurse delegate to the assistive personnel? And so when we look at these, what can we delegate? I think it's just, I guess one, not select all. And we can have them place them on their side, right? Because somebody who's vomiting, we can, because really this question and test taking strategy, right? It's not saying what intervention should we do for the patient who's vomiting. It's saying which activity can the nurse delegate, right? So it's so important we understand what are these questions asking us, because we probably are going to give them an antiemetic drug. We might be giving them IV fluids. They may even get an NG tube, but those aren't things that are in a CNA or assistant scope of practice. So it'd be placing them on their side, they can position.
I gotta read that word carefully. I thought it was antiemetic bag.
Yeah, right. So great point. Sometimes if you're thinking ahead, oh, maybe they can go get an anti-emesis bag or a basin, and we just kind of start reading and we're going, oh yeah, hit them we're not reading that it says drug, so important to read the questions as well as the answers as well. It's a great point. Okay. The biggest thing with nausea and vomiting, kind of got you guys brought up, is we're going to protect their airway, right? And then replace whatever they're losing. Obesity. I thought it was interesting that your book talked about obesity when it talked about GI system. But if we're talking about eating or the lack of eating or nausea and vomiting, overeating and lack of exercise, other factors can lead to obesity, which is a big issue in our nation. So we've talked a little bit about this already when we talked about metabolic syndrome. Remember going back last term? And so some of the things we look at with obesity, if you're just trying to do a general screen, sometimes they'll do waist circumference. And this isn't a one size fits all. This is a general screening. But if women's waist circumference is over 35 inches or men's are over 40 inches, that's a good indication that they probably are obese, right? Not every person is the same, but that's a general thing. Also, we look at body mass index. BMI is the abbreviation for it. A high BMI means that you are usually more overweight. Now, a BMI isn't a perfect calculation because really you just plug in somebody's height and their weight, and it gives you a number. And we know that muscle weighs more than fat. We know that some people are just built a little bit different. And so I don't like to go necessarily just by a BMI to say if somebody's healthy or not, right? It's a good indicator of maybe where they might be at. We do say you're overweight we as in the general healthcare community. 25 to 30 is kind of, hey, we're probably weighing too much than we need to, than what's healthy for us. And then 30 is considered obese. With obesity, we've talked about this a lot through the program in general, but it has comorbidities, meaning there's other issues that are probably going to come up in patients who are obese, right? They're probably going to have some atherosclerosis. What's atherosclerosis? Yeah, the plaque buildup in your arteries, right? Heart disease with that. Gallbladder disease, heart disease, hypertension, sleep apnea, type 2 diabetes, depression. Those all are often found with people who are obese. And so if we can help with the obesity, a lot of times it can help with some of these other things as well. This book, I'm not going to go in, or this picture is in your book. I thought it was pretty good. Look at it later when you're studying, because it really does give you a nice picture of like how obesity affects all of your body. Well, I wish I would have put, they have these pictures you can look online of x-rays of people, and where in the x-ray, you can see the outline of the person very large. And then in this inside, there's this skeleton. And the skeleton doesn't change. So it's very interesting. Oh gosh, now I just have to go find it for you guys because I really think it's fascinating. X-ray of obese person. Hopefully I don't come up with something horrible. Okay, so see this, I mean, I'm not fact checking any of this, but it says this is an x-ray of a 700-pound person, right? And so you can see the skeleton looks the same as any skeleton, but the body is so large, right? And so it's a good reminder that extra weight, we don't get extra bones or extra structure as well to hold up all of that weight. It has a lot of impact on the body. Okay. Hopefully there's nothing horrible on there that I'm showing you guys. All right, back in present mode. So we want to support, support weight loss. We've talked about a lot of things about how to support that in class, including support groups. This book, your book talked a lot about bariatric surgery. We're going to talk some about bariatric surgery because I think that it's going out of fashion or it's becoming less in vogue. Because actually, I'm going to ask you guys. So bariatric surgery, up until the last few years was very, I'm not going to say popular, but very common. We had a lot of people who had bariatric surgery of different types. What changed in the last few years that's decreased bariatric surgery for patients?
GLP, whatever.
Yeah, like Ozempic, right?
Yeah.
Yep, it's the medications, right? Like we talked about them for diabetes, but are also used for weight loss now. You can even get them easily from lots of different sources. People have had such success with that, it's decreased the amount of bariatric surgery. I was working with a surgeon, it's been a few months ago I have a per diem job where I work in surgery as well. And I was working with a surgeon who was new to the hospital. And I was saying, oh, where'd you come from? What's going on? She's like, well, I was in the bariatric clinic up, or where was she? She was from a different state. But when she moved here with her family, she couldn't get a job doing bariatric surgery because there just wasn't a need anymore. So now she was back doing general surgeries because they, most surgeons will train as a general surgeon first and then they'll go into a specialty. So now she was back to taking out gallbladders and appendix and things like that. And I was like, oh, I hope she's got this, anyway, but it was really interesting to me to think, oh, even these providers, they don't have a job anymore for some of this. It really has decreased. Now, maybe it will come back into fashion. I'm not sure, but I'm not going to really stick a lot of time with bariatric surgery today because you're going to see patients who have had it, but I don't think you're going to see a whole lot of people that are getting it, at least in the next 10 years or so is my guess. So, but just like anything, once you graduate, there's going to be things that come in fashion, medical trends, or new procedures that if you encounter them, then it's like, okay, well, let's make ourselves aware of it. Like we want to be aware of the top cancers that are in our area, right? And so we also want to make sure that we're aware of the top, maybe other things that are happening in our area. Okay, so some of the weight loss surgeries, like this is a band surgery here, where they have this band that can kind of adjust. It gives tension on the stomach, so you can't get a whole lot in there as easy. Sometimes they actually take out a lot of the stomach, so you're just left with a little piece of the stomach left. Here in this one, the Roux-en-Y, they essentially stitch off this part of the stomach here and then attach part of the small intestines up here. So you just have this very small area. Again, here you can see here, they removed some of the stomach and did like a diversion on here. So it's all taking up space or kind of controlling space that's in the stomach or removing some of it. We'll talk some about the side effects and benefits as well. We'll talk about that now. Okay, well, let's do this question first. So let's make sure we're reading questions and answers correctly. The nurse would teach the assistant personnel the benefits of providing oral care daily include which? We're going to select all that apply. Sorry, guys. Hey, good morning. Oh my gosh. Thank you for battling the printer. All right, so remember the trick with the select all that apply questions is look at each answer as true or false, right? So providing oral care daily is important to overall health. That's a true statement. The next one prevents pneumonia. Yeah, it does prevent pneumonia. Do you guys remember how it helps prevent pneumonia? It decreases all that bacteria that's in your mouth. So if somebody were to aspirate, if you were to kind of cough or get something down, it decreases how much of that might get into your lungs and cause a bacterial infection. Reduces ventilator-associated pneumonia. That is true, right? That's a true statement. If somebody is on a ventilator, we want to make sure we're providing good oral care because we know that if they're sedated, they can't protect their airway. They have probably an ET tube or a tracheostomy in, but if that has a leak or something, they could still aspirate something. So we want to prevent any of those secretions from draining into their lungs. And it gives patient comfort. Anybody like not brush their teeth for a day and just been like, oh, that feeling in your mouth, it just doesn't feel good.
Prevent aspiration is not an option.
Right.
But it does.
Well, it doesn't prevent aspiration. It prevents infection if there is aspiration.
But if you're suctioning, providing oral suctioning, that's oral care, preventing aspiration.
I didn't think about suctioning in that. I'll have to think about that. I would say providing oral care. I mean, if they have a lot of suction, if they have a lot of secretions, suctioning could prevent aspiration. So you could make a case for that. But just general brushing their teeth, cleaning the mouth in general isn't something that directly prevents aspiration. Okay. The big things we want you guys to know, oral care is really important. Remember we talked about patients with like infective endocarditis. You know, we want to make sure that they can, we don't have some big infection in the mouth that can then travel to the bloodstream, right? And so for some patients, we want to prevent any of that bacteria getting loose and spread, like patients with heart valves, a lot of times with total joints, things like that. We want to give them prophylactic antibiotics, so they'll get antibiotics before going to get their teeth cleaned. To prevent any of that bacteria causing issues. I'm not going to get into all of these. These are like oral health care issues. Thrush is probably one you guys will see more in your career, right? And that's the yeast infection in the mouth. What does that usually look like? Little white patches. Yep, usually the tongue, mouth, sides. It's very painful. And then xerostoma. You might see that, which is dry mouth. Sometimes certain medications give people dry mouth. All right, so cue recognition. You're caring for a resident of a long-term care facility. He reports his shoulder hurts from arthritis and he can't clean his dentures. You notice he has dry lips and his dentures have food on them. So turn to your people next to you, your peers, and real quick, let's say, what would we do? What do we do for this guy?
It's like the. Scrabble strike thing.
All right, let's check your answers against FA David. So they said, hey, first, let's gather more information about that shoulder pain. What is that? What's happening? Right, because we think shoulder pain, maybe arthritis, but what else present like shoulder pain? Heart attack. Next week, we're gonna talk about gallbladder issues. Sometimes people can feel that pain in weird areas too. We want to assist him with his oral care or delegate that to somebody else to do. And then until he can have good function mobility in that shoulder, we're gonna make sure it's probably on his care plan and we pass that on, that he needs help with his oral care. He can't do that on his own. Okay, some oral inflammatory disorders, right? Because, and I guess some of the question is, well, why do we talk about these? This isn't serious medical issues, right? But it really is, especially when I think about our older population or at-risk population. If they have thrush or canker sores or other things, it's going to be more painful for them to eat and drink. And it's very easy for them, especially our older population, to get dehydrated. They're not eating enough already a lot of the time. And so this can be very detrimental to their health. So canker sores or ophthalmostomatitis, it's an inflammatory response that people can get. It can be stress. Maybe you're studying for a test, you're in nursing school, who knows what's going on, but your body has a stress response and you can get these canker sores. And if anybody had a canker sore before, I've had them before. They're very, very painful, like just raw. And then there's also herpes simplex type 1, which is cold sores. And that is it's a viral infection that once you have it, it's just living dormant inside you, but it can be stimulated by some others, also like canker sores. It can be stimulated by stress. And then you get these sores, usually more like can be inside, but outside the mouth too, you can see. Both of them have over-the-counter treatments. Did we talk about it? Oh, it doesn't. So things that like topical pain relief, like Oragel, if you've heard of that. A lot of times talk about it for babies, but you can use that for these as well. And if it's for herpes simplex or cold sores, you can have antivirals. You can even get them over the counter that will help with that viral outbreak. Oral cancer, the highest risk of this is going to be from alcohol or tobacco use, right? We know that those two things have an increased risk of cancer. Signs and symptoms, difficulty chewing, swallowing, speaking. If it's detected early, very curable. But if not, it can really be quite devastating. Esophageal cancer, this is usually detected later. Again, alcohol and tobacco are big risk factors, but because a lot of the symptoms that people have of maybe having a little more difficulty swallowing, maybe a little pain with swallowing, it's not as prominent as with the oral cancers. And so it's less likely to be detected. Barrett's esophagus, you might see this on people's charts. It's where people have certain, it's a diagnosis where essentially they have some like precancerous areas on their esophagus. And it doesn't mean they have cancer, but it means they are more likely to get esophageal cancer. And so for those people, we screen them pretty regularly. My son and my husband both have an autoimmune disease. We aren't going to get away with another week of not having Preston be part of our, case study here. But my husband has Barrett's esophagus, and I always get on him when he doesn't want to take some of his medication or other things. I'm like, you are already halfway to cancer. Like you've got to get your screenings. And he's like, I don't want to do another scope. And I'm like, well, I don't want you dead. So anyway, just know if patients have Barrett's esophagus, we need to make sure that we are screening them for esophageal cancer. We talked about this. Hiatal hernia. You guys are probably going to see a lot of patients that have hiatal hernias. I think we have we do have pictures. Good. So if you can imagine this blue piece, that's the diaphragm, right? Your diaphragm makes a really good seal across the middle of your abdomen. And what comes up through there? Yeah, well, your esophagus. Your esophagus is the only thing that should come through that diaphragm. Sometimes, if there's weakening in the muscles there, If, a lot of times if we're overweight, there's extra pressure that's put on your internal organs. And so some of that stomach can kind of be pushed up through that diaphragm. Sometimes a whole little like piece of it can be kind of like plopped on there. So your esophagus is much different than the stomach. Your esophagus, it all works on muscle contracting to push things down into the stomach. Once food is in your stomach, what is your stomach doing to that food? Digesting it, right? How does it digest that food? Enzymes, right? It secretes enzymes. It's a very acidic little home right there. So if you have some of that acidic home sitting up here above the diaphragm, oftentimes it will flow back up into the esophagus. And people often will have heartburn or GERD, which is gastroesophageal reflux disease, because of the hiatal hernia. Oh, did I go back on this? Yeah, that's pretty much it. So most commonly, man, smoking really is bad for you, right? I feel like everything we see, it's like smoking makes you more at risk. If you're older, if you're obese, or pregnancy, because like I said, that extra pressure that's put on your internal organs, it makes you more likely to have that poke up in there. What's that? Yeah, go ahead.
Okay. I was a bit people who was down, and then.
Oh, yeah, we're gonna talk about that. Yeah, so a hernia is just a weakening of a muscle where other tissue, whatever's there, is kind of poking through. This is a hiatal hernia. So thank you for clarifying that for me. Hiatal hernia is that weakening of the diaphragm where the stomach kind of pokes through. So it's important we know hernia, we have lots of types of hernias. So make sure you know the difference between the different types of hernias, because I'm 100% sure some of them will be on the test. Oh, I said test. Everybody's listening. Oh, hey, Juana.
Hi, everyone.
Hey, do you need a minute?
No, I can ask you. There's a. But there's an advisory meeting. With one of your students that attended that thing. Saturday.
Oh, yeah.
Did we have some here? Or
We did.
do you want them just to touch base with you when? Probably around 9:30.
Okay.
If there's some, if there's.
Break at 9:30.
They just want to hear like. Ask them some questions and hear about that experience, so probably like 10-15 minutes.
Okay.
Yeah, like 1 or 2 students.
Okay. If you went to the, what was it called? The,
MSWA, Nursing Students of Washington.
yeah, the conference that was a couple weeks ago. Yeah, I think Julius.
That
It was on Saturday.
Yeah,
It was a Saturday.
Oh, was
That sounds like it was just happening.
It was a long time ago. So if you went at 9:30, if you could go down to your office.
Yes.
There's just a little conference where they just want to hear back from students who went to see if it was a good experience. So, thank you so much. So we'll take break at 9:30 and then you guys can go share your experience with it. Okay, we were talking about hernias, but I think we were done with hiatal hernias. And, oh, what can help with it? So smaller meals will, how will smaller meals help?
It's not filling it up, so.
Right, your stomach isn't just like packed full, right? More full stomach, more pressure to push that food up. We don't want people to recline an hour after eating. You can sit down, but don't lay down flat, right? Because you're more likely to have that reflux up. A lot of times we say, raise the head of your bed. Sometimes people will try to sleep on pillows, but most patients seem to kind of slip down off of those pillows. So they usually will say your bed in general, put it on a couple blocks, like at the head of the bed. And that way your whole bed is kind of inclined a little bit. And then they say, before bedtime, avoid eating for about 3 hours so that when you do lay down, your stomach is empty. Also avoid spicy food, alcohol, caffeine, and smoking. They can all irritate that. They can do surgery, and if it's extreme, causing a lot of pain, people aren't able to eat and drink like they need to, they can do a surgery to cinch up that diaphragm, and especially if that stomach's been looped up, kind of suture it back down in place. Okay, so we already kind of talked about this. We often say GERD or G HERD. And that's like, heartburn is like a symptom of it, but sometimes they'll say I have heartburn. But what they mean is they have gastroesophageal reflux disease. And that's when you have the gastric secretions that flow up into your esophagus, right? And because our esophagus, it's a much, I don't want to say safer place, but it's not so acidic as our stomach. And so it hurts that mucosa when it flows up into the esophagus. And a lot of times it's because that lower esophageal sphincter doesn't close up all the way. So we have this sphincter that from the bottom of the esophagus to the stomach, it should close, right? It opens as our esophagus is pushing food down, and then that lower sphincter closes to keep the food in. Sometimes if it doesn't close all the way, it allows stomach contents to flow back up a little bit. And you feel heartburn, which usually people say feels like burning in the middle of their chest. You know, it feels aching sometimes, regurgitation, hoarseness, sore throat. And then diagnosis, I mean, yes, they could do an upper endoscopy where they do a tube scope down the throat, look into the esophagus, look into the stomach. That's pretty extreme. But they also will probably just look at symptoms and then sometimes try a treatment of medicine that might help. What kind of medicines are going to help with GERD? Yeah, like some antacids. Yeah, something, maybe a proton pump inhibitor, something that's going to decrease the overall acid production in the stomach. Yeah.
Yeah, what about the coughing? System coughing?
Oh, yeah. Yep.
My daughter had a cough throughout.
Yes.
Putting the sleep up. How amazing was to listen to that was her.
Yes.
But then she sometimes she coughed. Then I checked, I remember I had gone along. So I raised the bed.
Yeah.
And then, antacid and I was putting up food.
Before she-
Yes, and.
Oh, that's amazing. Yeah, so coughing at night, especially, or when you're down, that can be a sign of reflux because as that fluid comes up, it might trigger kind of a little bit of a gag cough, and you're coughing because you have that fluid or gastric contents that's come back up when it shouldn't.
Is the pH monitoring, is that similar to like doing a strip or something?
Yeah. Like if you have reflux, the pH in your mouth is going to be a little bit lower, because it'll be more acidic than normally because of those gastric contents that keep coming up. It's usually symptom based. I'm going to tell you, they don't usually use these as diagnoses most of the time. So complications, right? If you have reflux, can cause asthma, right? Can cause some irritation, eventually. Aspiration pneumonia, that's a really big one. Bronchospasm, laryngospasms, chronic bronchitis. Ooh, Barrett's esophagus, like I talked about earlier, precancerous. Oh, I talked about it here too. Gotcha. Well, I don't think there's a whole lot on it. They can do ablations to remove the tissue. So sometimes when my husband does go get his scopes, they will remove some of the tissue there if it looks particularly concerning. But really they're just monitoring for any cancerous tissue that looks concerning. So with reflux, hopefully we can do a lot with lifestyle changes. Like we just talked about when to eat, what not to eat, stop smoking, drinking. Sometimes, just like you guys said, you might do some antacid, some antihistamines, or proton pump inhibitors just to reduce the amount of acid that's in the stomach itself. Education, we're going to talk about, losing weight. If you're overweight and that pressure is causing the reflux, we're going to encourage them to help lose weight. We're also going to talk about eating a low-fat, high-protein diet, avoiding the trigger foods. My husband has horrible reflux because this disease he has. And we've discovered anytime he eats popcorn, he gets horrible acid reflux, right? Isn't that a weird thing? Like even if it's air popped, like natural popcorn, it will always give him reflux. And so you want to teach your patients, hey, when do you have the worst acid reflux? What seems to really bother you? Because it's not always if I went out and ate tacos with the spiciest salsa, right? That might be great for some people. Other people, it's something totally different, that man, every time I eat potatoes or, that's what gets me. Is potato a nightshade? I can't remember, maybe, I don't know. It's really interesting, some of the triggers that people have, garlic, onions, you know, like there's certain foods that just really will trigger the reflux in patients. Mallory Weiss tear, I'm not gonna talk a lot about it. It's not gonna be on the test. Just know it's a big tear in the esophagus. Biggest risk is people who have prolonged either coughing fits or really more vomiting. So if you ever have somebody who comes in and they have a Mallory Weiss tear, well, I shouldn't say it's not gonna be on the test because I don't know, maybe I'll put it on. But the biggest issue, if you have a tear in your esophagus, you're probably gonna have a lot of bleeding, right? So if you think about, like, if your esophagus ruptures, there's gonna be bleeding, you're probably gonna be vomiting, there's gonna be blood, there's gonna be a lot of pain. Is that somebody that we can say, okay, hang tight, here's an emesis bag and go see somebody else? No, it's an emergency situation. That person needs to be, they need to be in an emergency room if they're not, and they're probably gonna need to go to the OR right away as well.
Patient had, Mallory.
They did at clinicals? Oh, how did they treat it?
They gave her it's a it's a quad type of treatment, so there were like 2 antibiotics, a
Mhm.
PPI,
Mhm.
and forgot what the other was, maybe an anti.
So maybe it wasn't a full tear then.
Yeah.
So if it's a partial tear, partially through the esophagus, not fully though, and then a full tear would be where you would need to go to the ER or the operating room. So I'm glad you said that. So partial, you can have a partial tear where it's not all the way through, and we watch them really carefully, right? Because we don't want that to fully perforate, because then your esophageal contents, possible stomach contents are just going out into your chest cavity or stomach cavity. No good. Bum, bum, bum. Gastritis. So gastritis is thrown around a lot, and we can use word building to figure out it's just gastric irritation, right? You can get gastritis from all kinds of things, from eating this spicy salsa, or from a bacterial infection or a viral infection. A lot of things, or medicines, right? We talk about, I heard somebody talking about ibuprofen and taking it on a full, needing to take it with food. Was that you guys? Right? Because we know it can cause irritation to the stomach lining. So we want to make sure it's taken with a big glass of water and some food because it can cause irritation or gastritis. It can be chronic or just episodic. The biggest thing we want to make sure is that if it's chronic, it can cause perforation or even scarring of the stomach. We really want to prevent that. It's gastritis, abdominal pain, tenderness. You might feel full or feel gassy. They might have reflux or feel like they're belching a lot. And then we want to treat whatever the cause was and then avoid the irritating foods. And then sometimes we might give them some antacids or antiemetics if they're feeling kind of nauseous with it. There can be some chronic autoimmune gastritis, usually is in the stomach portion itself. A lot of times they aren't necessarily symptomatic, but they might be anemic. And so because of that, if somebody has pernicious anemia, right, which we talked about last week, sometimes they might look to see if they have some autoimmune gastritis going on, if that's what's causing them not to be able to absorb
Vitamin B.
vitamin B12. Good job, good job. So pernicious anemia, vitamin B12. So there can be some chronic environmental gastritis. So infection from H. pylori, that's one of the biggest things. When somebody says they have like acid reflux or they feel like they have gastritis a lot, if they have H. pylori as a chronic infection, it will cause this gastritis and cause issues. Do you guys know what we give to treat that? Erythromycin, yeah, an antibiotic, yep. And that's usually, it's very treatable, right? They might also get some PPIs. And there can also be stress-induced gastritis, right? Every nursing student sometimes I think feels like maybe they have a gastric ulcer from being stressed from all the studying and school and everything. But from being stressed mentally or physically, it can cause these ulcers to form. Or just the increase in stomach acid, lack of protective mechanisms. So people who are critically ill, we really want to watch them. So a lot of times, it used to be just, I would see it mostly in the intensive care unit. Those patients were almost always put on a proton pump inhibitor or something to help reduce acid in their stomach, to help reduce their chance of having gastritis. But I'm seeing it more just for regular patients in acute care in the hospital. Oh, the batteries too. That was a good drop. Anybody see people like in your rotations that in clinicals that are on like antacids, protonics, things like that, but they don't have heartburn or other issues? I would look, because a lot of times you'll see patients in the hospital that they come in, kind of how sometimes we do DVT or deep vein thrombosis prevention, right? We'll put people, we want to make sure we're always preventing blood clots. So we put SCDs on patients, we get them up, they're walking around. A lot of times they're on heparin shots or Lovenox. We also do some prevention with gastritis too. So a lot of times patients will be on some sort of proton pump inhibitor or something to help prevent them from getting gastritis while they're in the hospital because they're ill. They don't necessarily have to go on it when they're home as well.
That patient had a small bowel obstruction.
Oh, yeah.
on a PPI.
Yeah, yeah, a lot of times they'll do that because especially if you think about small bowel obstructions, it's not moving through, everything's backing up. And even when you're not eating, your stomach is still producing little bits of acid. And so if that's not going anywhere, man, that can get really painful. Okay. So as a group, I want you guys to prioritize these patients. We're going to talk about it in a minute. So I want you to rank them in the order that you would see them. So think about if you're in clinical and you receive, or you're working, you receive these patients, who do you go see first, second, third, fourth? And I want you also to say why. Why would you see them this order? So 1, we have Mrs. Wilson, who had a gastric bypass 4 hours ago and reports nausea. 2, Mr. Lee has gastritis and reports he vomited. It was red colored. 3, Mr. Morris was admitted with a Mallory-Weiss tear. His blood pressure is 118/68. And 4, Mr. Swanson is 1 day post-op for a total gastrostomy for gastric cancer and reports pain of 6 on a pain scale of 0 to 10. All right, so in your groups, get together, decide why, how, and why.
Yes, what?
Yeah.
She called me like a while ago and said she was very late.
Okay.
She was on her way, she just had to rush back home.
Okay.
So she was so good at being here.
Oh, okay. Thank you. Okay, let's go ahead.
Yeah.
And everybody have their answers kind of locked in place? Let's go ahead and see what F.A. Davis says. So we need to see Mr. Lee first. Why do we need to see him first? Right? He was vomiting red colored. That's concerning, right? And then we want to, the first thing we want to do is to get his vital signs, see how he's tolerating that. Next, Mrs. Wilson should be second. Anybody have Miss Wilson second?
Yeah.
See a few people. That one was a little bit tricky because Mrs. Wilson just had gastric bypass 4 hours ago and she's nauseous. We know that because of that smaller stomach area, If she starts vomiting, man, she could aspirate. We don't know. And who knows what kind of medications that she's still on, if she's still semi-sedated. We want to prevent her from aspirating. And we need to check if she starts, and the bigger thing too is because of that new incision, right? Whatever type of gastric surgery it was, there's a new incision there. And if you're vomiting, you're putting pressure on that. We really want to decrease patients having vomiting after surgery with their stomach. And then let's see, Mr. Swanson is third. You medicate him for pain. And then last is Mr. Morris, which I think sometimes we see Mr. Morris and we're like, ooh, he had a Mallory Weiss tear. We know that's like where a tear in his esophagus, but it just says he was admitted with a tear. There's really nothing about him that makes us concerned, and we know that his vital signs are stable. So that's why it puts him at the bottom of the list of needing to see him. Okay, we'll do some more prioritization actions later as well. Okay, so Mr. Lee says he has gastritis and he vomited. It was red in color. He's 56 years old and has history of alcohol intake. He just vomited approximately 250 milliliters of bright red emesis. So these are our vital signs. Before he vomited blood, 98.8, heart rate 72, respirations 14, pressure is 136/78. Current, so this is after he vomited blood, 98.8, heart rate 98, respirations 18, blood pressure 102/56. Has he changed at all? Yeah, he has. So now we're going to communicate with the healthcare provider because we know, right? We get the vital signs and then we want to let the provider know right away. So think about what you would tell the doctor and present it using ISBAR. So take just a moment, collaborate with your buddy next to you. How would you inform the provider about this? Question?
Yeah.
Oh, to the vital signs too? Yeah.
Background.
Hey, you're all good. I'm glad you made it too.
Learn that the situational stuff, but then you have to fight because those situations.
All right, let's go ahead and compare what you guys said and let's compare to F.A. Davis. One thing I do want to make note, does this person make you nervous? Yeah, I've been a nurse for a long time and this person would make me very nervous. It should. I mean, should we leave them? No. While I'm going through to call the provider, I'm probably gonna say, hey, charge nurse, whoever, old season nurse, like get somebody crusty like me. And say, go help me, go sit with that patient for a while. They don't look good. I'm concerned. I'm uncomfortable with them, use the cuss. So just so you know, you don't be scared alone. Don't be nervous alone. Find your people, right? Because that provider, I don't know where he's at. They may or may not be in the facility, or she might be out, might take her a while to answer her page. So we want to make sure we have our people around us to help. So we talk about SBAR, we're going to identify, right? Make sure you always say, this is so-and-so, I'm calling from so-and-so. Because we know that providers, if you're at long-term care facility, you might have a provider who is covering many long-term care facilities. And so you need to make sure you say which facility I'm calling from. We talk about, hey, the situation is urgent, right? We're letting them know, hey, right up front, this is a priority. Mr. Lee was admitted with gastritis, has vomited twice with 250 mils of bloody emesis just now, history of alcohol intake. Why is that history of alcohol intake important? It causes, right? We know it's an increased risk factor for gastritis, a lot of other things. Next week, we're actually going to talk about esophageal varices as well. And with alcoholism, liver disease, your risk of esophageal varices, which are essentially the blood vessels in the esophagus get kind of distended and they can burst and cause horrible, some of the worst bleeds I've ever seen are from esophageal varices. So that's a little preview to next week. Background. his blood pressure has decreased from 138 to 78, or 138, 78 to 102 or 56. His heart rate has increased from 72 to 98. I believe he is bleeding. Recommendation, he needs fluids and to be seen by you. It's okay to be very direct. You can say he needs a provider to see him immediately. That is okay to say that. And then you want to make sure you read back orders. So if they say yes, you need get some IV fluids. You need to read back, okay, I heard you say an IV bolus of 500 milliliters, normal saline, administer packed red blood cells 1 unit now, make NPO, prepare for possible endoscopy. Excuse me. So whatever they tell you they're doing, we always read it back and prep them for it. Okay, peptic ulcer disease. So that's that erosion of the gastric lining. Very curable, right? And H. pylori is a big one. What was the medicine I said we usually give for that? Yeah, erythromycin. Increased risk, shocker, smoking, alcohol, and NSAIDs. So you can have gastric ulcers, which is in your stomach. You can also have duodenal ulcers, which that's kind of the beginning of your small intestine there. So sometimes you might have, your pain might be a little bit different. One of the big things, oh, I was even looking for this because I wanted to find a way for you guys to remember it. Essentially, it's gastric. It hurts after you eat. So if you have gastric ulcers, you get pain after you eat. With duodenal ulcers, oftentimes it's pain on an empty stomach. And so a lot of times the pain is relieved. If the people with duodenal ulcers, if they eat, that pain is better. Usually they'll eat things that are very mild, potatoes, crackers, things that are bland, that will help with them. So not everybody might feel the pain the same. And if you're wondering what kind of ulcer they have, ask them, when does it hurt? Is it when you eat, like after you eat, or is it when your stomach is empty? Is that when it hurts? Signs and symptoms. Well, they don't want to eat sometimes. If eating causes them to have pain, oftentimes they won't eat. Nausea, vomiting, there might even be some bleeding. Eventually, if the ulcer gets bad enough, it could even perforate through the gap through the stomach, or cause obstruction. So usually we want to do a test for H. pylori because we know that's the most common, or I think it's the most common. It is the most common. They might do some GI series or an EGD, but usually they're going to test for H. pylori and possibly do a culture with a scope. So the nurse would include which of these medications in the teaching plan for peptic ulcer management. Select all that apply. Yeah, good job, you guys. So antibiotics, right? We probably with the H. pylori, we need to give some of the antibiotics. Proton pump inhibitors and H2 receptor agonists to decrease the amount of acid the stomach is producing. Calcium channel blockers, nope, that's pretty much, you're going to be thinking about your heart for those. And then bismuth subsilate. I have a hard time saying that one. What's another name for that? You guys remember?
Yeah.
Pepto-Bismol. Yeah, the pink thick drink, right? That is can be very helpful for pain relief for people with peptic ulcers. It kind of coats the stomach and helps provide a little bit of analgesia for that. We just talked about that. Treatment, avoid the irritants. And then if it is from H. pylori, let's take those antibiotics. So what about this? You're caring for a patient who has a duodenal ulcer. The patient's scheduled for an endoscopy later this morning. The assistive personnel just put the patient's breakfast on the bedside table. What do you do? First of all, what's an endoscopy? It usually like an EGD. So where they go down the throat with a camera and tube and then look down in your throat and in your stomach as well. All right, so turn to your people next to you. What do we do?
Scratch that. I think they're probably.
Okay, let's compare your answers to F.A. Davis. So remind the patient and the assistant caregiver that the patient is NPO. This is why it's so important that we educate our patients. I've had so many times where a patient who is NPO has rang their call bell because they're like, somebody just brought me in water or somebody just delivered my tray. I'm like, oh, thank you for calling me instead of just eating that because they're not supposed to, right? So we educate our patients. Don't just say don't eat, tell them the why, right? Ensure that the food and fluids have been removed, and then make sure, do we have an NPO sign up on the door? Because, right, we're all fallible, right? I might forget who is on contact isolation of my patients and might accidentally just walk in and out if it weren't for the signs that we put up as visual cues to help remind us, hey, put contact precaution gear on before you go here. Hey, they're NPO. Hey, they're aspiration risk. There's a lot of signage that you'll see that's put up to help us remember how to take care of our patients. Okay, gastric bleeding. So this is I want to say, I guess, a symptom or it's something that happens because of something else. You don't just suddenly have gastric bleeding. You have a Mallory-Weiss tear or a perforated gastric ulcer. You have something going on that's causing bleeding in your stomach. Oftentimes we talk about gastric bleeding and sometimes we'll say GI or gastrointestinal bleeding. Usually we separate them by upper and lower bleeds. You have an upper GI bleed, usually stomach, a little bit of small bowel, or lower GI bleed, a lot of times in your colon. So signs and symptoms, it depends on how severe it is. If you have a little bit of bleeding, not very much, you might have a little weakness, diaphoresis, your H&H might be a little low. Severe, you might go into shock, weak pulse, palpitations. Like if you're losing a lot of blood, that's when we're going to see a lot of severe complications. I guess maybe I never talked about Preston yet. He has fun, right? Who this kid is like collecting conditions, like they're like Pokemon or something. I don't know. But when he was 8 or 9, I think I told you guys he had an anaphylactic reaction to nuts. And we took him in to see an allergist. And the allergist, I actually made a family appointment because I said, hey, we all probably need to get checked. You know, if like my daughter, maybe she has allergies. My husband hadn't ever gotten as an adult, like the allergy testing. So we all did it. And this allergist sat down. He was looking at my husband and he was like, you've had these upper endoscopies because of all these issues he had had. And he goes, you have this, well, he called it EOE, but it's eosinophilic esophagitis. You guys don't need to know this for your test. You'll see on some commercials and things, some medicines for it now. But it's eosinophils. You guys remember what kind of cell? They're not a red blood cell. They're a white blood cell. Specifically, when you have like an allergic reaction. Allergic reactions will trigger eosinophils. And so if you have eosinophilic esophagitis, we can word build, right? Esophagus, itis, inflammation. And so it's a autoimmune disease, a lot of times hereditary, oftentimes with men, but my husband's sister also has been diagnosed as well. So not always in men. And it's where you have reactions to some sort of allergy, something that's causing an allergy. And it causes irritation in the lining of the esophagus. Sometimes it can even over time create these furrows and scarring and then these strictures where you can't swallow. That's why my husband had been having them because since he was like late 20s, he would have trouble swallowing food and food would get stuck. And so a few times he would have to have upper scopes and they would go and they would dilate his esophagus and we never really knew why. And then eventually it was this allergist who was like, wait a second, you have EOE. And then he was looking at my son, who he was always like really like, he's kind of like beefy now, like he goes and works out and has muscles, but he was really scrawny as a kid. And he was like, I bet he has it too. And I was like, what? And he was like talking to my little kid. He's like, does food ever get stuck in your throat? And my son was like, yeah. And he was like talking to him about it. And I was like, what? Like, he used to complain about carrots. He would hate eating carrots and some other things. He's like, no, mom, they hurt my throat. They get stuck. And I'd be like, shut up and eat your carrots. Like, come on. Like, you're just complaining about eating your vegetables. What I found out, because they had to end up doing a scope on him and do biopsies, is that he had severe gastritis and esophagitis from this disease. Carrots were probably getting him like stuck in his throat. And he was anemic actually from this constant, just like a little bit of blood loss and lack of some of the good nutrition that he needed. Fortunately, very treatable. He takes an immune medication. It's every 2 weeks, and it helps to kind of decrease his immune system from attacking his throat. It can be from, so his was from foods, all these different foods. We found out he was allergic to peanuts and tree nuts and fish and milk and gluten and all these things. Wasn't like an anaphylactic reaction like those, but that was causing irritation in his throat. Sometimes for people with EOE, it might be allergens in the environment, like cats, dogs, pollen. Sometimes I found out it was people even just reflux. If you had acid reflux, that reflux would cause a autoimmune, like an allergic reaction, like inflammatory response. But very treatable. It's very treatable. It's just so funny that my son, again, has just one more thing. But he didn't have, from his little bit of gastric bleeding, he didn't have big symptoms, just little symptoms. He was fatigued, he was scrawny, he was anemic, wasn't a big deal for him. Other people have big bleeding, like our Mr. Lee, I think we talked about, right? 250 out, that's a pretty big amount to be losing. Because if we think about if somebody's vomiting blood, they're vomiting the excess that's in their stomach a lot of times. That means there's probably still blood that's in their stomach, blood that's been digested or being digested as well. And so we want to make sure we just know that that's probably not all the blood that they lost. Okay, gastric surgery. We've talked a little bit about this. We talked about gastric bypass. They're very similar in how we treat them and kind of some of the side effects, things like that, right? Because we're taking away part of the stomach's space, right? We're decreasing that amount. So you can have subtotal gastrectomy or total. Subtotal means you take out part of the stomach. Total gastrectomy is you remove all of the stomach. So it's important to know if somebody's had a gastrectomy, do they have, right? Because if you have a subtotal, you still have part of your stomach, you're going to be able to eat and drink more things, larger volumes than people who have totally had their stomach removed that have no, like our stomach is a reservoir, right? It's a little space for food to get digested. If people don't have a stomach at all, man, they are going to have to really modify a lot how they eat. So here is just some pictures that I don't love, so I'm going to scooch by them. Oh, is this the subtotal? Oh, gotcha. I guess I do. I'm okay. That's why I left this picture in. Sorry, I'm trying to remember. Why did I leave this picture in? This is the subtotal. So maybe this is the area that maybe had cancer or something wrong with it. So they cut this off and then they took that and attached it down here to the small bowel. So subtotal gastrectomy, they took off part of it, but not all of it. This next piece is a total gastrectomy. So maybe they had cancer all through the stomach here. And so they removed all the stomach and then just brought up the duodenum, this lower or upper intestine, and attached it right up on there. Yeah.
So the stomach was cut and put on.
Oh, not the esophagus. Good question. The small intestine. I hope I didn't say that wrong. So here, this one, the stomach is put onto this is like where the jejunum is at. So here, this is the duodenum, like where you have your stomach goes into the duodenum, goes into the jejunum. Here, they kind of join it a little bit later onto the jejunum because they might have part of the duodenum. So it's part of the small intestines. And then in this total gastrectomy, they remove all of the stomach and then just sew it directly into the jejunum here. Oh, they probably will have, right, because they don't have that pyloric sphincter. They probably will have a lot more acid reflux because they don't have the stomach for food to contain in. Lots of small, frequent meals, after surgery, most of the time, they're doing mostly liquids for a long time. These patients with total gastrectomies, we really have to focus on nutrition. It's a huge part of our care for them. Good question. Which intervention should the nurse include in the plan of care for a patient after gastric surgery? So remember, if it's a true or false for each one of these, which ones do we include? All right, nice job, you guys. So yes, we monitor vital signs, we manage pain, and monitor the incisional site. What kind of breathing do we encourage? Deep breathing. Why do we do that? Prevent atelectasis, prevent pneumonia, right? And then maintain bed rest,
No.
right? What do we want them to do? Yeah, get up and walk. That's going to help with DVT prevention, atelectasis prevention. It's going to improve peristalsis, all those things. So surgery has complications, right? Now, sometimes this was the area where it's just talking about gastric surgery, like a total or subtotal gastrectomy, but these are the same as the bariatric surgeries. So if you have patients who have a bariatric surgery, these are going to be the same risks that come alongside. So that's why I cut a lot about at the beginning. F.A. Davis had a lot that wanted me to talk about bariatric surgery, but it's the same thing, right? Anytime you're decreasing part of the stomach, you're removing it or doing something, you're going to have these be possible as surgical site leak, right? So what's the surgical site? Where is it at? Well, but in the stomach, yeah, right? So you're taking off part of the stomach and stitching it back together. What's going to be leaking out of there? Like gastric contents, right? Right? And so usually it can all stay inside, but it's a risk that we want to monitor for that there might be a little bit of leaking at that surgical site, right? And so if there's leaking, what is going to happen? What might that patient have? Not skin breakdown because it's internal, right? It's the stomach is the incision, so pain, pressure, fullness, aching in that belly is where you're gonna like inside is where they're gonna have that pain.
But if they have to do that laparoscopically or something, or, if they did.
Oh, so there will also be an external incision too.
That's not what that.
Nope, because surgical site leak, when we're talking about gastric incisions or gastric surgeries, yes, you're gonna have an external incision here to access the stomach. But when we talk about a leak, that's specifically about the organ or the place that we did surgery on. So the stomach, or even like with a bowel, I think, was it your patient had a small bowel obstruction, right? If we have small bowel obstructions, sometimes they have to remove part of that bowel and like remove it and then connect or anastomose, reconnect those pieces together. Those might have surgical site leaks as well. And so hopefully everything is put back together how it should, but in the stomach, it might leak out some stomach juices, which is very acidic, in the bowel, if that has a leak at the surgical site for like a small bowel obstruction, we worry about bacteria and other things. So we all have good bacteria in our gut that's helping us digest our food. It's good in our gut. It's not good in our peritoneal cavity. It can cause infection. Okay, dumping syndrome. Dumping syndrome is something we see often with these patients with gastric surgery or bariatric surgery because they don't have that little reservoir to digest the food, and it goes in right to that jejunum and then just kind of it takes the fast track all the way out, which is kind of gross, but like they eat and then they poop and they eat and they poop. And so they're not having that same time to absorb all the nutrients, to absorb what they need to out of the food. Because of that, often they can have nutritional problems where they're not getting all what they need in. Hey, that pernicious anemia. Right, we see it again. A lot of times we don't have what we need. We don't have that stomach contents to break down those things. We end up being deficient in what vitamin?
Vitamin
B12. Yeah, and so you might have these patients with pernicious anemia. And so a lot of times patients with either gastric surgery or bariatric surgery are gonna be on B12, injections kind of for life sometimes to help keep them, from being anemic. Do you guys remember what steatorrhea is? I don't think I'm saying that very well. Steatorrhea. Fatty stools, yeah, very fatty stools. How do you know if a stool is fatty? A lot of times it looks mucusy, it probably will float more, right? So if you're assessing your patient's stool, if it's all very, very fatty, frothy, buoyant, it probably has a lot of fat in it, which means they're not digesting it like they should, right? It's actually a good assessment tool to be able to use. And then they might get even some obstructions too, we want to look at. Oh, that's the end. Okay, well, look, that kind of ended up in a pretty good time. Okay, so we're gonna take a break. When we come back, we're gonna do some group work, so make sure to get your group, uh, whatever, from the bag of equity. Let's go till 9:25. And so that gives you a little bit longer break, and then if you went to the conference this last weekend, please stop by Juana's office so you can give a little like what it was. I think it's more just thanking the school for providing opportunity and so they feel good about sending our students to stuff like that. Okay, I'll see you guys at 9:25. All right, hopping in here because I want to make sure that we get done. So lower GI is anything past the stomach, right? Small intestine, large intestine, rectum, and anus, then out. So first question, if the patient hasn't had a bowel movement for 4 days, the abdomen's distended, and the patient reports bloating, what do we do? And this is a select all that apply. You cry? You cry? Your patient might be crying. Okay, nice job. So yes, we want to make sure we're adding fiber to their diet, right? So they're all true or false. True, we add fiber to our diet. Ambulate, yeah, because we know that ambulation increases peristalsis. Elevating the head of the bed doesn't really do anything for helping move the bowels. We do want to increase fluids and notify the healthcare provider. Yeah, if you're looking for the code, oh, it was up here or there.
Notify health provider is not.
Oh, shoot. Did I say that? What I meant to say was we don't notify the healthcare provider immediately. Immediately is the key word. If our patients haven't had a bowel movement, we probably do want to notify them, but it's not an immediate concern. We don't need to do a 911 call to the doc right then because it's not an emergency, but we do want to notify them. Maybe they haven't had a bowel movement by later today, next time they round, want to make sure they're aware. Okay, constipation. You guys know a lot about this. I'm gonna kind of skip over some of it. The big thing is the longer that stool stays in the rectum, the more it pulls fluid, so it gets harder, more difficult to pass. So the longer that patients are constipated, really the harder it's gonna be for them to have that be resolved. You guys know signs and symptoms, but sometimes we don't think about headache, fatigue, low appetite. Those can all be signs and symptoms of constipation as well. The complications, well, they can be impacted, right? If that stool isn't coming out, it can be impacted into the rectum, and sometimes it has to be disimpacted, and we have to physically pull the stool out. Zero fun. You can get ulcers, hemorrhoids. Patient might be screaming, causing those hemorrhoids to happen. You can get something called megacolon. That's where you are usually so impacted or you're so full and then all the gas and bloating folds up, and on an x-ray you can see this dilated loops of the bowel, and it's in this colon, it gets so big. They can even have what's called toxic megacolon, where all of the toxins from the stool kind of leak out through the system as well. How do you diagnose constipation? Well, usually patients will say, hey, I go to the bathroom, I have a bowel movement every day, every other day, whatever their normal is, but now it is longer than that, or they feel full, or they are not able to go. They might have a exam. So therapeutic measures, we've talked a lot about all of these, so I'm not going to go over them. Sometimes with constipation, it can be a tricky topic that some people just don't want to talk about. My husband unfortunately has all these GI issues, and one of his least favorite topics is poop and farts, which are like my favorite. And so he's like, do we have to talk about this? And I'm like, yeah, it's interesting and funny. But for him going to the doctor, he's very adverse with talking about it. I'm like, you can't say you're fine. He's like, yeah, I'm fine. I'm like, but you're fine? Like what's normal for you, that isn't fine. So you need to make sure you tell him what is normal for you. Anyway, so establishing a rapport, just knowing that not everybody's comfortable talking about it. Maybe even just prefacing, saying, hey, I get that it's uncomfortable to talk about, but to help you, I just really need to know a couple things. Sometimes just level setting can help patients feel more comfortable telling you. Diarrhea, right? The opposite of constipation. It's where you are passing fecal matter too rapidly, where your colon isn't able to absorb all the liquids. And so it's usually very liquidy. It can be bacterial or viral infection. Maybe you have an allergy, it's an allergic response. Biggest thing with this is to prevent, right? We want to teach about good hand washing, good preparation of food to prevent viral or bacterial issues, and then avoid whatever causes the food if it's a food. So you guys know the signs and symptoms, frequent watery stools, cramping, diet, like we got all that. You guys know. The biggest thing with diarrhea is we want to figure out what is the cause and treat that. We also want to help symptom treatment, right? Because we know if they're losing a lot of fluids, we want to replace the fluids. We might give them Lamodal or Imodium to help slow the peristalsis, right? Help keep some of that stool that they can absorb it. We might even order some probiotics, right? Because we know, especially with our patients who have antibiotic therapy, right? It's not specific. If it's topical, maybe it's more specific, but if they get IV or oral antibiotics, that targets bacteria through your whole body. So it's killing off not only the harmful bacteria, but also the good bacteria in your gut. And so a lot of times we want to encourage these guys, hey, you might get diarrhea. I might kill some of the good bacteria and cause diarrhea. Take some probiotics and replace some of that good bacteria. Fecal transplants. I used to work in a unit that did these. I thought it was really interesting. Have you guys heard of fecal transplants at all? There's some interesting, I know, questioning looks, but for patients, especially with C. diff, is usually where we would see them, and they were in immunocompromised patients, and they could not get the C. diff to resolve. And so they were hospitalized for it. They were so fluid deficient, so weak, could not recover. And so they would get a donor. Usually it was a loved one, and the donor would be sent home with a sample thing, and the donor would bring it back in a little bag, and then they would mix it up in an enema bag with some fluids, and then run in that sample, and all of that good bacteria from the donor would then go in and recolonize the person that had these whatever C. diff or other issue. It sounds horrible, right? It's like, that's disgusting. But let me tell you, those patients, by the time they got to that point, they were desperate. They'd been in the hospital for a couple of weeks, or been where they couldn't leave their bathroom at home forever. They desperately wanted some fix, and they were like, yes, do that. I know, it's kind of wild. There's a lot there. Anyway, there's a really interesting documentary I saw on Netflix that talked about the science of poop or something. Oh, I'll find it and I'll share. It was so interesting though. Anyway, so fecal transplant might be last case, right? It's not the first thing we run to, but it is effective for our patients.
Where can I find the slides for this? It's not there.
Oh, the slides aren't there? Oh dear. Hold on. Three. Let's see. Oh, no, I don't upload. Huh. Hold on a second. Yes. Chapter 27 wasn't there? Okay. Give me 1 second to put this one on here and I will change that too. Okay, we're missing 34. Okay, it should be in the week 6 resources now. And which week was not there? Which PowerPoint wasn't there? 35? Okay. I will add that in. Wait, but for last week, it was 35? 27, okay. I was like, that doesn't, 35 doesn't sound right. 27 does. Okay, I will add 27 in later today. All right. Is this where we were at? All right, so let's go back into this case study. I would say Mr. K and ask him how to say this name. Kasperzik, a 70-year-old white male, was admitted to telemetry with hypokalemia secondary to diarrhea. He has hypertension. The parentheses mean that's where he is right now, not hypertensive. His potassium level is 2.5, and he has IV fluids D5.5 with 40 of potassium running at 125 an hour. He has a potassium level ordered every 4 hours. The next one's due in an hour. He has a loose stool 30 minutes ago, and he has had a stool culture sent and awaiting results. You're preparing to give handoff at the end of your shift to the oncoming nurse. Think about the information you want to include. We're not going to do to each other because for purposes of time, let's just see what F.A. Davis says. Says, hey, our situation. We've got this guy with diarrhea and hypokalemia. He has history of hypertension. We say this is what his current potassium is, IV fluids, last stool, and blood pressure. Recommendation, probably should be put on a cardiac monitor and needs some monitor his potassium level. The next one's due in an hour. That's about it. Okay, so changing topics. Appendicitis. Anybody had their appendix taken out that wants to tell or say? Yeah, a couple of you guys. So the appendix is kind of an optional little piece of our intestines that we don't really know exactly why we have it, but it's this little loop. Whenever I'm working in recovery room and somebody comes in to have their appendix taken out, I always ask the OR nurse to see the appendix because I'm always so curious. Because sometimes people appendix are like these little tiny things, and sometimes they're like really long. And so I don't know, I just think it's fascinating. But it's this little pouch, very skinny, that comes off of your, like, you know, those like long balloons, like that I had you guys blow on for cardiac a long time ago. That's kind of the shape of them. They're very skinny. But they can have things that get inside of them and get irritated or infected and cause a lot of pain and issues. The first thing that we notice usually is people have fever, nausea, vomiting, and they have pain in that right lower quadrant. So kind of go over to your hip bone, and then come in a little bit. This is McBurgey's point, your right lower quadrant. That's usually where people will have pain related to appendicitis. It's very intense, right? These people are hurting so much. We usually, for diagnostic tests, they're going to do a CT scan is usually what will definitively confirm that they do have appendicitis. We also want to get a CBC because what are we going to look at in that CBC count?
White blood cells.
Yeah, they're white blood cells. It's going to tell us if they're infected or not. Oh, here, look, it shows you McBurgey's point that we already saw. They're most likely, sometimes with light appendicitis light, if it's not too bad, their symptoms aren't too severe, they might do a scan and it doesn't look like the appendix is too inflamed. They might just trial antibiotics and see if that can treat it. Sometimes that works. Oftentimes, by the time it gets diagnosed, a lot of times it's gone on for a while and it needs to be surgically removed. The concern is that they want to remove it before it perforates or opens up, because if that bowel, right, it's part of our bowel, opens up, it's gonna spill that infection, but also all the GI flora, good bacteria too, into our abdomen. Do. Linda is a 40-year-old Black woman presenting to an urgent care facility. She reports severe right-sided lower abdominal pain, nausea, vomiting, anorexia. She states she woke up with pain a couple hours ago and rates it a 7 out of 10. What do we do? Any ideas?
Yeah.
Make her NPO, probably get some pain medicine, send to a CT. Any other, yeah, what kind of labs do we want?
BBC.
CBC, rest. Yeah, don't get up and move around. So FA Davis says, yeah, let's get more data. Let's get vital signs. Let's see if we can hear bowel tones on there. Ask her about her last bowel movement, food intake, look where the pain was at, and talk to the healthcare provider. This says that she might be getting appendicitis. I also, if this was my patient, she is 40 years old. It doesn't talk anything about menstrual status or if she can still, what's that called? Not menstrual status, what? Like if she can still have a baby. That's called something. Reproductive status, I guess. I don't know why my brain's like just, but
Fertility.
fertility status at 40, she might still be able to get pregnant, right? This could be, if this was my patient, my recommendation would also to be to get, if she's not had a hysterectomy, even on birth control that can fail, right? I would recommend a HCG, the test for pregnancy, because this might be an ectopic pregnancy causing the pain as well. So just something to consider, right? Just because we say, oh, this looks like appendicitis, it doesn't mean we want to ignore other things too. Yeah.
A patient, I was in triage at clinical last week.
Yeah.
And she came in and so she had this pain
Yeah.
in her right lower. And so the doctor came in there and she
Mhm.
straightened her leg and she was like, ah.
Yes.
And she was like, this looks like appendicitis.
Yes.
And so.
Yeah, that's one of the things you can do. You straighten their legs and it has that referred pain up there. Bum, bum, bum. We talked about this. Sorry. Okay, peritonitis. We talked about peritonitis a little bit when we talked about renal, about the peritoneal dialysis, right? So the peritoneal space, it's just kind of that space that holds in all of our organs. We can get peritonitis occasionally but it's usually there's some sort of cause that happens, like a ruptured appendix, right? All that bacteria and things spilling out into the peritoneal area, or peptic ulcer disease. You have an ulcer that has ruptured, open to the outside area there. Sometimes with pancreatitis or diverticulitis, that can also result in the peritonitis. So with that, it's just severe abdominal pain. It's not in one spot or another. It's that whole peritoneal area, even wrapping around a little bit. It's just very achy, painful, pressure. A lot of times we'll do labs, look for a high white count. And then sometimes they'll just do exploratory surgery because if somebody has like, man, this looks like peritonitis, but we don't know why, they might want to go in and look to see, okay, is there something going on in the bowel or around there that we just don't know about? We want to make sure they're NPO because they're probably going to go to surgery and it's probably might be not food, but it might be something with the bowel that's causing it. And so we want to kind of rest their bowels. And then they might even have an NG tube as well, because again, we want to rest the bowel, not let even the gastric juices go through. Boo, boo, boo. Okay. I highlighted these because I think they're kind of confusing. So diverticulosis and diverticulitis. So on your intestines, they're kind of those smooth, slippery tubes, right? And so you can get diverticulum, and that's where outside of the bowel, you have this little outpouching, kind of like the appendix, but usually a little bit smaller. We have pictures. Oh yeah, we do. So here's the diverticula. Like, see, normally the outside is all smooth, but you can have these little pouches, and you don't necessarily have to have one or two or three. You can have however many your body wants to grow, right? It might just be one or two, it might be a bunch. But diverticulum is that little out pouchy, just where you just form a little pouch just because your body decided to do it. You have diverticulosis when you have, or I guess it's diverticulum is a single. Diverticulosis is when you have multiple of them. And then diverticulitis is when they get inflamed and or infected. Because they're that little pouch, it's really easy for things like seeds or nuts or little fiber things to get inside of there and kind of stuck. And then when it gets stuck, that's oftentimes where it gets irritated, inflamed, and then infected. So that makes sense with our patients who have diverticulitis. We recommend, hey, let's avoid foods with seeds or little nuts. Let's watch what kind of things we're eating to kind of protect those bowels. The issue is when, I skipped. So causes chronic constipation, or if they don't have enough fiber in their diet, we don't necessarily know why it causes that, but it does cause that. As you get older, you increase your risk factor for it. Signs and symptoms, a lot of times there's no sign or symptom until you have the diverticulitis when it gets infected or inflamed, and then it has a lot of pain and irritation. So if you have diverticulosis, you might not even know it, and it might not even be a problem. It's not a problem. It's just when there becomes an infected or bleeding or infected area, or if it starts bleeding, things like that. They usually will do a CT scan if they suspect that, and they'll do a colonoscopy. Well, they'll go up and look to see if they can find where those diverticulum are at. So what do we do for them? If they're mild, if they're just causing some pain, some irritation, usually they'll have them be kind of on more of a liquid diet, maybe some Tylenol things to kind of help kind of rest the bowel and give it some pain relief. If they're severe, then we're going to help with pain control with probably more than just Tylenol. And then also instead of a liquid diet, just NPO, and send them to surgery so they can go try to fix that. Because the more severe that infection is, the more the inflammation is, the more risk it is of it perforating. Because those little diverticulum can perforate, and then that's going to spread infection out into the peritoneum. Okay, Crohn's disease. So we've talked a lot about immune system. We've probably heard about Crohn's disease, and it's where you have parts of the intestine, and they call them skip lesions because it's not the whole part of the intestine that's involved. It's like this area of the intestine, and then it skips over it. There's a good patch of intestine, and it kind of skips to the next, and then an area that's affected, and it skips to another area. So it's not all areas of the intestine, just certain ones. Kind of like most autoimmune disease with Crohn's, there's remissions and exacerbations. What usually causes exacerbations for patients? Stress, maybe food, right? All the things that with any autoimmune disease can cause worsening of symptoms. So this one, I kind of like this picture because ulcerative colitis, which we're going to talk about in a minute, it really, it's kind of the red area is supposed to be like the impacted area. That reddened area is ulcerative colitis. See how it's all one long area? It's all affected. Where Crohn's disease, it's kind of patchy, where you have this red area here that's affected, and then it skips over here, but then now we have another impacted area here. So with ulcerative colitis, it's not the entire portion of a bowel that's affected. It kind of skips over one area to the next. So with Crohn's disease, because that area of the bowel is becoming very inflamed and irritated, they have a lot of pain in their stomach. It hurts when they eat. They get diarrhea. They lose weight. Their fluid and electrolytes are probably all out of whack. And so what do? A lot of times these guys, they want to do a scope. They want to say, okay, let's go look and see what's going on. And then usually they will do different types of medications. A lot of these, like the 5 aminosalicylates, biologics, actually the first 2, those are like affecting your immune system directly, right? They're trying to suppress the immune system so it doesn't attack the colon. Corticosteroids, you guys know, right? It's a steroid. It's also going to help with inflammation. They might do some immunomodulators or even just like symptom management added on, right? They're not just gonna give somebody with Crohn's antidiarrheals, but they might give them some of these other medicines and say, when you're having diarrhea, take these antidiarrheals. If the nurse is preparing to administer budesonide or entocort with breakfast, which intervention should the nurse complete prior to administering? Prior to administering. Yeah, okay, nice job, you guys. Take that grapefruit off the tray. If you're not sure, if you're like, man, what is that medicine for? What are we doing? Well, it has a little clue on here where it says Entocart EC. What does EC stand for? Usually EC is enteric coated. Enteric coated. So it's a type of extended release. So do we crush them? No, we don't crush them. We probably don't need a daily weight. And even if you're like, man, I don't remember specifically, but I know grapefruit is really bad for a lot of medication interactions. So if you're just doing some test taking strategies, that grapefruit is a key word there that you know that grapefruit interacts with a lot of medications. Oh, excuse my itchy nose. So with the Crohn's, we want to avoid foods. They know their trigger. Sometimes they have to have surgery to remove some of those affected areas of the bowel. Sometimes these guys have to go on a special type of nutrition, like we have our tube feedings that we give to patients. Sometimes with these guys, they need specially formulated ones that are like broken down to be like just amino acids, basically, so that they can more easily digest them. And then complications, right? We've talked some about they can be malnourished. They might even get fissures in their rectum, abscesses. They talk about fistula on here. Oh yeah, they do. Sometimes with the diseased portion of the bowel, it can open up, right? And it can actually form what they call fistulas. Now, a lot of times students will get confused thinking about dialysis fistulas. But this type, like a bowel fistula, is where essentially you have part of the bowel that's kind of created a new opening to go somewhere else. So with these, you can see how here's the bowel, but it is opened to fistula, enterovaginal fistula, right? So these guys, if this happens, and I've seen patients with this, they have bowel that comes out of their vaginal canal because they have a fistula that's opened internally there. Sometimes you can have external fistulas where it will open up to the outside. I took care of a woman years ago, I'll never forget, and she had several fistulas that had opened up to the outside of her stomach. And so we put on several ostomy bags to try to contain that. And she went in for several surgeries to go ahead and repair those, but it was a battle for her. There's also some that can go like into the bladder, like they can go all over. They usually will need to surgically repair these fistulas, but they're really tough because usually it's a diseased bowel that will form these fistulas. And so it's not a healthy bowel that will respond very well. Okay, ulcerative colitis, which remember that's one different from Crohn's, where it's kind of one section of the bowel that's usually affect. They also have remissions and exacerbations, so very similar with that. Again, we don't know, but it's an autoimmune system as well. So it's very similar, ulcerative colitis to Crohn's in some of the signs and symptoms and what we do for it. These guys have a lot of stools, like we're seeing 4 to 10 liquid stools every day. And just like you'd expect with somebody who has that much diarrhea, they're going to have weight loss, cramping, fever, dehydration, all these imbalances. So these guys as well are going to have a lot of risks of hemorrhoids, perforation, peritonitis, osteoporosis, right? Because of some of the electrolyte imbalances, their body's going to be pulling from their bones to get calcium. And then they're also increased risk for colorectal cancer as well. These guys as well, they're going to get some stool specimens, other things. Why would we get the stool specimens?
Inflammatory markers.
inflammatory markers, and make sure there's nothing else going on, that they don't have like a parasite or something else like that. We don't want to miss something up as well. All right, the nurse is caring for a patient with ulcerative colitis that reports anorexia, 5 stools a day, and rectal bleeding. Which action should we take first? Another one of those prioritization questions. Okay, I'm gonna be honest, I don't remember what the correct answer is, but I think I know what it is. Okay, well, I'm gonna put myself out there. Just like most of our NCLEX style questions, you can kind of narrow it down between these two. Right? And it's asking, this is a priority type question, right? Which is the priority for us? So if they have anorexia, they're not eating or drinking. 5 stools a day is a lot, right? They're probably losing fluid, electrolytes in that. What's my first action? I think it's vital signs. I'm gonna check. But it has to do with our ABCs, right? Circulation. I want to find out about the characteristics of the stool, but if they're just coming in and I'm finding out they're not eating or drinking, they're having a lot of fluid loss with that diarrhea, my first thing is going to say, how is their body tolerating it? Is their blood pressure still high enough? Oh, I hope I'm right. Oh, good, I am. Ooh, it does get kind of nervous when anyway, so hopefully that makes sense, right? We want to look at the stool. We want to ask them about the characteristics, but we also want to make sure, first of all, do you have a pressure to support it? Are you really low pressure? Because I don't want them passing out because they're so dehydrated while I'm asking them questions about their stool. Okay, same treatment as Crohn's, right? We're probably going to give them some biologics, autoimmunes, antidiarrheals. And again, these guys might need surgery. So see how there's a lot of commonalities, Crohn's and ulcerative colitis. Excuse me, patient seen in the emergency department with abdominal pain and a history of Crohn's. He's been resting in bed when suddenly he reports extreme abdominal pain and is curled up in a fetal position. What do we do? All right, let's see what FID visits. Let's reassess him, right? He has changed, and if our patient status has changed, we're gonna reassess. We're gonna look at his bowel, or his belly, see how that's doing. It might mean that he's having a complication, and we need to notify the healthcare provider that he has changed. Irritable bowel syndrome. You're gonna see probably a lot of patients out in clinical or depending where you work that have IBS is how they shorten it. And IBS is more of like a it's a function problem, not a dysfunction of the bowel itself, right? So ulcerative colitis and Crohn's, that's actual, the bowel itself is diseased, right? There's an issue with it. IBS is more of where it's not working as it should. So you can have a couple different types. Sometimes people have IBS with diarrhea. Sometimes they have IBS with constipation. Sometimes it's both, right? So it just depends on the person. And so if essentially somebody comes in and they're either having a lot of diarrhea or a lot of constipation, and they've done all the tests, like, okay, well, it's not ulcerative colitis, it's not Crohn's, it's not all these other issues, they might say, okay, this is more of a functional problem with your bowel, and you might have IBS. So with that, it's more common in women, tends to be hereditary. So we might see if if we're asking patients about it, we might ask their parents, or about their parents. And it also has triggers, so interesting, similar to the autoimmune, like if there's stressors or different foods. In women especially, they'll see some of these triggers around their menstruation. So with hormonal changes, they might see triggers with it. But a lot of times, depending if it's IBS-C or IBS-D, meaning constipation or diarrhea, that's the signs and symptoms we're going to see. It's going to be either feeling full and constipated and not able to have a stool, or it might be you feel full and maybe some nausea and grumbly tummy and having diarrhea. So it all just depends. There is a lot of correlation with patients with depression and anxiety. There's a lot that goes into our chemical makeup in our brain, and our mental health and our gut health. I've got to find that documentary for you guys because it was really interesting, the one about the poop and the fecal transplants, because it did talk a lot about patients' gut health. And if they had a healthy gut with the normal things they should have in there, they tended to have healthier mind overall, like their brain health, their mental health was a little bit better. Okay, I'll find that for you. I'm gonna write this down though. Poop documentary. Okay, so therapeutic interventions, low FODMAP diet. Have you guys heard of this? FODMAP stands for fermentable oligo something disaccharides. Polysaccharides. It's in your book. It has like a little breakout box on it. But essentially, some of those foods, like I talked about earlier with, like my husband with popcorn. Corn is one of those foods. I can't remember which one. Or garlic, or onions, or there's different food groups that can be very irritating to certain people's guts. And so FODMAP is like, I don't know how many, 5 or 6 of them, I think there's different groups. And so if you can figure out, especially these people with IBS, which of these groups are causing your issues and eliminate them, a lot of times you can have a big relief of their symptoms. It is quite a bit though with patients because usually they'll say, okay, eliminate all of these FODMAPs and then introduce in, maybe you start eating, garlic and see how that goes. But that can be a lot to eliminate food. Then you have to wait for several weeks to not eat it. And then if you eat it, you have to then wait for a bit, see how you do. So it can be hard for patients to eliminate all of that. But, also with IBS, high fiber, right? That's always going to really help our digestive health. Avoid foods that are trigger, stress management, eating smaller meals more frequently, exercise. There are some medications that help. It just depends on what type of IBS, whether it's constipation or diarrhea. I'm not gonna test you on the medications. Bum, bum, bum. Okay, hernias. Anna, here we are. Hernias. So remember, we talked about a hernia is just a protrusion. It's like you got weakness in a muscle somewhere. And so then you have protrusion. I think, was this cohort that we went to a long-term care facility back in the fall? And there was a gal, was up in Federal Way. Yes, and she had the biggest, was it your patient, Shiley? Was it your patient that had the giant hernia?
Yes.
Yes. Okay. So guys, I'm going to be honest, especially with my first semester clinicals, when some students come to me and go, she has this big thing and it's like it's a hernia. She's like, it's so big. And I'm like, how cute. Yes, it is. The first time you see a hernia, you're like, oh, wow, this thing. This was the biggest hernia I've ever seen. It was it's like she had it's like she was pregnant with triplets out on her belly. Like it was so big.
It was so big, like how much it would literally, was almost like the stomach was almost like clear, like a sheet.
Yeah.
Yeah.
You could see through it much better. Yeah. Yeah. So that was the biggest hernia I've ever seen. Most hernias, so you're gonna have a few different types. So I actually had an umbilical hernia when I was a baby. Very common for kids to have umbilical hernias because you think about, right, the umbilical cord, that's a connection between the mother and the baby, right? Once the baby is delivered, that area usually heals and seals just fine. Sometimes there can be a little weakness left there. I had to have surgery on mine, so now I have like a little scar here. Other times you can have general weakness. A lot of times the femoral area can be an area where there can be weaknesses and it weakens that area of the muscle. And then there's a outpouching of whatever's inside, right? So down in here, maybe our intestines. Men can have inguinal hernias, right? And so like where the scrotum are at, sometimes there can be hernias that they have to go replace as well. Sometimes you can see abdominal hernias, like if they're midline or something. That's usually from people who have had surgeries in their belly and they haven't totally healed. The muscle is weak and they've had a hernia through there. Or sometimes with our pregnant mamas, you can have the muscles kind of separate. You guys learned about that during maternal, and so those weakened muscles, sometimes you can have a hernia that comes through there. My aunt had hernia surgery, and when I think she called him Ernie, she like named her hernia, and she'd be like, "Oh, Ernie's giving me problems," and she would feel it poke out, and she would poke him back in. Which is good, right? If you have an Ernie, you want to put him back where he belongs. But there's sometimes when they're so large or they can't go back in. The issue is if we can't go back in, that there's a weakness, and if something pokes out through there, usually it's your intestines, something going on. That hole isn't huge, right? The more you cough, sneeze, do whatever, the more it's gonna come out usually. And you're not gonna get perfused, right? You're gonna have a little bit of what can be called strangulation. And valve can start to die and they need surgery right away. Okay, let me catch up to my slides. Where are we at? Here's the different types, like here's umbilical hernia, direct inguinal, femoral hernia. A lot of signs and symptoms, they just have like a little bulge or something, like they might, and if you have a patient with a hernia, please ask them to feel, and you want to actually palpate, because where that hernia is at, you're gonna feel muscle tone, and then you're gonna be like, whoa, just like, whoa, you can dive in there, because it's an opening in that muscle area. It's very interesting. We want to make sure we teach patients about it, because if they have a hernia and something starts pouching out, we want them to like, hey, put Ernie back in, or you need to call your doctor if he won't go back in, because that's a problem. Intervention, support, they might even have to have surgery. Sometimes they'll do surgery to put back in. Sometimes they'll even put a mesh in the abdomen or in the femoral area, and it's a surgical mesh, not like from Ace Hardware or whatever. But they put that in inside to kind of help hold that space where it won't pouch out again. So if somebody has a hernia, and this is pretty much when they have hernia or after surgery, we want to say no coughing or lifting. Why is that? It's gonna push hernia out, right? It's gonna cause it to pouch out. We also want to talk about supportive garments, and that's post-operative as well. Because if you have a hernia, you'll often do like abdominal binder or something to help give support there. Before surgery, just to help hold everything in. After surgery, hold it in, give support. It also helps a lot with pain as well. Activity limits. Okay, absorption disorders. I'm not going to talk a lot about this, but it's where you have, it kind of makes sense. So, right, like most of us have heard of celiac. I feel like that's pretty much in our society right now. Like we know people have gluten issues. Celiac, it's actually like an autoimmune reaction where your body is reacting to it and you're not able to absorb nutrients like you should after you're exposed to it. Same thing with lactose, right? People who have a lactose intolerance, they can't absorb that like they should. And so when you get exposed to these things, those two are like most common that people are familiar with. If you're exposed to that, what usually happens? What are signs and symptoms? Diarrhea, right? Right? Your body is like, oh no, I don't like that. I'm going to get rid of that. It gets rid of it. It also gets rid of hydration, your electrolytes, your nutrients. So it does cause problems for patients. A patient's admitted with celiac disease, what data should be reported immediately? Fatigue, blood in stool, foul smelling stool, or diarrhea? Yep, blood and stool. Good job, you guys. We talked about that. I don't care about that. With the therapeutic interventions, right, we're going to avoid what causes a trigger. Some of these things, if they continue to have diarrhea, weight loss, things like that, we're going to hopefully consult some dietitian, figure out what can we feed them that's going to not cause problems and maintain their weight. I feel like we need a break. Yeah, let's do a break and then come back for the final piece of this and then some NCLEX questions. So 35 after, I'm going to say it right this time. Come back at 35 after, and then we'll finish strong. All right, that is it. Recording. So we're gonna be able to fly through the rest of most of this stuff. So intestinal obstruction, anytime you have something that is blocking where it can't come through, can be from a bunch of different things. It could be mechanical, right? Where the bowels are not actually working appropriately, or it could be non-mechanical, like something is actually stuck in there. One thing to know, this high-pitched tinkling sound, that's probably gonna, I won't say you're gonna hear it in the see that in the NCLEX, but I feel like that's one I often hear that people have as like a NCLEX type question that they get, talking about high-pitched tinkling noises in the abdomen. And that's usually when we hear that, we think obstruction, bowel obstruction. If we have the non-mechanical obstruction, like something's actually blocking it, usually we just don't have bowel sounds. But the high pitched sounds, our body is trying to move, still trying to move things through. There's a couple things that you might see. Intussusception, and that's like telescoping into the bowels. Did you guys learn about this at all with peds? I was gonna say, I see this more in our pediatric population, where you have the bowel, right, which is like a big tube, and then essentially that tube telescopes in and kind of folds in on top of itself. It's incredibly painful. So when we see this, like in pediatrics, these kids are crying. They are inconsolable. They are in so much pain. And then you also might have, with mechanical, you might see a volvus. And that's, I think V, because I think like this little guy here reminds me of a V. So I think volvus and like twist. That for some reason in my brain that helps me make sense of it. So the volvus is where you have part of your bowel, but it like twists on itself, like you're trying to tie up a bread bag or something. So with all of these guys, regardless of what type of obstruction, you're going to have severe abdominal pain. You're probably going to have some nausea, vomiting. You might have some blood and mucus in the rectum, depending on what's going on. Fecal vomiting. I've only seen this a few times, but that's where you have an obstruction where usually the patients are impacted. And so stool can't get out. So it builds up, builds up, builds up until it gets all the way to their stomach and then they vomit stool. It's pretty awful. It means that that constipation's gone on a very, very long time. They usually have a lot of abdominal distension, and then fluid and electrolytes are all in balance with them as well. Usually they're going to do some x-rays, maybe a CT scan for these guys. And what do? Well, we're going to keep them NPO, right? Because if they have an obstruction, nothing's going through. So we don't want to put anything in that's just going to get jammed up in there. And we usually put an NG tube in. What kind of suction are we going to see usually put on patients? Low intermittent suction, right? Low intermittent suction. That's going to be the standard. We're going to give them fluid and electrolytes, and we're probably going to give them some pain medicine as well to try to help with all that pain that they're having. And give them maybe some antiemetics too if they're nauseated. And then sometimes if we can't get this, usually they'll try bowel rest is what it's called, where nothing to eat or drink, an NG tube to keep even the stomach contents from going through. And if it can't resolve on its own after a couple of days of bowel rest, that's usually when they'll go in with surgery and try to surgically replace or fix what's going on. Okay, this is another prioritization activity I think is going to be good. So Sirio, did I say his name? He returned from a 2-week vacation, lucky, with reports of diarrhea for 2 days, anorexia, leg cramps, and some fluttering in the chest. Ooh, I know what I would highlight in here, right? The healthcare provider has ordered an NG tube, stool for culture and sensitivity, continuous cardiac monitor, and an IV. With a partner, indicate the priority which you will complete the healthcare provider orders. So go ahead for just a moment, turn to your partner, people next to you, and just kind of put those in order. If these are your 4 orders you get from the provider, which one do you do first? Or what order do you put them in?
Or. The IV. Sorry.
And then. George. And then.
Okay, let's compare and see where we're at. So remember our test taking strategies. What's our highlighted or important information here? I would say, so a 2-week vacation, right? That means it's something different than the usual. He reports diarrhea for 2 days. I would highlight that because I know that diarrhea for 2 days is going to have some fluid loss, electrolyte imbalances, leg cramps, and fluttering in the chest. Ooh, I would also highlight those, right? Because I know that those are signs of some electrolyte imbalances. So if they've ordered all of these, which is the first? So remember, when prioritization, what's a good tool to use or a good way to prioritize? ABCs. So who had the cardiac monitoring first? Anyway, I believe that's the correct one. Yes, because if we think, okay, they probably have some electrolyte imbalances and they already are exhibiting signs. He's got fluttering in the chest. We need to know right away, okay, you probably have some arrhythmias. What arrhythmia do you have? Because that's really going to inform us, how do we respond to this? If he's having little runs of VTAC, that lets me know what, like, how severe I need to go right with it. The next step is going to be IV, right? Because he's going to need some IV fluids, probably some electrolyte replacement, access in case we do have to code him or do some other things. But it's going to come second to that heart monitor, because the heart monitor is going to let us know right away, is this an emergency or is this not? Then we're going to put the NG tube in. And then lastly is going to be the stool for specimen. Any questions with that? Feel like we're kind of on the, we're getting there, right? It's a skill. Test taking is a skill. You guys are getting better at it, but you don't get perfect overnight. We're going to keep practicing. Okay, anorectal problems. Guys, we're almost at the end of our digestive tract. We're going to exit soon. Hemorrhoids, anal fissures, and anorectal abscesses. What a way to end. Okay, so if you have any of these issues, a lot of times they are controlled surgically, or even if just say somebody has, let's say hemorrhoids, for instance, we're going to do a lot of the same things, right? We're going to be looking at pain control with these guys. Sitz baths. Anybody ever given a sitz bath or seen kind of what one is? They used to do them a lot with these little tubs you would put in a toilet seat, and then you'd have like an enema bag essentially running in warm water. Anymore, I feel like what we tell patients to do is, if they have a bathtub, you run water fill a couple inches, and then you have them sit in the bathtub, you keep water running, and then you open the drain. So there's like a continual, like, fresh water in and then like old water kind of out. What it's for is if you have any of these issues, especially if you've had a hemorrhoidectomy or some of these anal surgeries, we want to make sure it's been kind of flushed a little bit, like just clean. They're still going to be pooping, right? That's going to be a big thing with all of your patients. If they have surgery, on their anus, they're going to be scared of going poop, but they're going to have to go poop, right? That's how things normally work. And so we want to make sure that everything is clean. It helps with irritation as well with the sitz baths. Because of that concern with having stools, we're going to give them some stool softeners, right? We do not want that stool to become hard and difficult to pass, because that's just going to interrupt or irritate the surgical area. Okay, lower GI bleeding. We talked a little bit about the upper GI bleeding. With upper GI bleeding, you're going to see usually bright red blood, vomiting. Lower GI bleeding, that's usually when you see those tarry stools, those dark stools. Blood, when it's digested, ends up being kind of like dark or coffee ground looking. Sometimes I say coffee ground stool. Can come from a bunch of different things. You can have a bright red stool. I guess what I should say is the stool, the blood will look differently depending on where it's at in your intestines. So if you're bleeding near your anus, maybe it's hemorrhoids, you're gonna have bright red blood, or you're bleeding somewhere in your lower, like rectum area, bright red blood. If you're up a little bit further in your digestive system, you're in your small intestine somewhere and you've got a bleed up in there, well, that blood is gonna be digested a bit and it's gonna look different. It's gonna end up looking more coffee ground. You get further down, it's gonna be tarry looking. It's gonna be looking a little different. Anybody smelled a GI bleed stool? You'll probably not forget it. It's some of those things that are kind of like C. diff smells real special. GI bleed stools smell very special. You'll walk in and you'll go, who has a GI bleed? Because you will smell it. It's pretty awful. And I don't want to dismiss that as well, right? That's part of our assessment, right? That's actually a very useful part of our assessments are those smells. So we're going to monitor them. We're going to do vital signs for sure if we think there's bleeding. Oftentimes we're going to do a guaiac or a fecal occult blood, right? We're going to make sure, especially if it's, that dark stool, coffee ground stool, it's still going to show up positive on that fecal occult blood if it truly is blood, but we're going to do that testing to make sure. And then colorectal cancer, major cause, lack of dietary fiber. I'm also going to say there's a lot of correlations with smoking and alcohol, right? Like, I feel like everywhere, but the biggest symptom they're going to have change in bowel habits, right? Just like everything else with different cancers, right? It's something that's normal for them. All of a sudden is different. Oftentimes they'll start to have obstructions and that's where the cancer is found out because they're not able to go to the bathroom. They feel constipated. Something is blocking in there. And that's how they discover the cancer. They want to do a colonoscopy. They might do the CT scans. With the cancers, they might have to do resections. And if they have to resection the bowel, oftentimes we will find ostomies, right? That's why usually we have ostomies. It's for either some sort of blockage that wasn't repairable normally or from a cancer that they had to repair. So they can put in different ostomies. I'm not going to go into a lot of this because we've talked about these before. Bum, bum, bum. We teach them. You guys know pink to red is normal for the stoma, right? It should look like bright, like pink, like it's very that dense color. If it's pale, it's not getting enough blood flow to it. And if it's bluish or like just white, then it's probably starting to get like either necrotic. Well, black would be necrotic, but it's on its way there. All right, the nurse notes decreased bowel sounds and clear lung sounds, pink red stoma, and no drainage for the stoma for a post-operative patient who had a colostomy placed 6 hours ago. What action do we take? Do we notify? Actually, let's just go through this one at a time. True or false? Is it true we should notify the healthcare provider that the stoma is pink or red? Yeah, right? That's a normal finding. We don't need to. True or false? Continue to monitor their status. True, right? We do. Encourage turn, cough, and deep breathe hourly. True, we should, right? If they just had surgery, we want to encourage them to decrease atelectasis. Ambulate with assistance as ordered. True, we want that after surgery. Monitor from flatus from the stomach, or stoma.
Yeah.
True, yeah, because what does that tell us? Yeah, the bowels are working, they're moving. We are. Just like somebody after a general bowel surgery, we actually ask them, have you passed any gas? Right? And then we're like, yay! When they do it, silly, but that lets us know that things are working as they should. The gas is the precursor to having a bowel movement. Okay, let's go ahead and get back in your groups because we're going to do some more NCLEX style questions.